Alrighty guys, welcome back to Nursing Made Simple. Today I'm going to be covering asthma. So we're going to cover what it is, who gets it, why we care about it, some of the signs and symptoms and triggers, and all those kind of things that you'll need to know to pass those nursing exams. So let's jump right in. I have the definition of asthma right up here on the board in this blue box. So asthma, a acute, fully reversible airway inflammation, usually occurring after exposure to a trigger. So the key with this asthma is it has to be fully reversible or it's not actually asthma. When we treat it with a bronchodilator, your rescue inhaler of albuterol, whatever the treatment is that you've been prescribed, if it does not fully reverse the asthma, you're not having an asthma attack. There's something else going on. It is more common in children, very common problem with kids actually. Mostly boys when they're in childhood. The younger the child, the more likely it is to be a boy, and then as we move towards puberty, that ratio kind of evens out, pretty even between boys and girls. And then into adulthood, it is more common in women, oddly enough. It reverses itself. I have written down here what I'm going to call the asthma cascade. So we're going to just jump right in and talk about what actually causes these problems with asthma. So first off, to have an asthma attack, we need some sort of irritant, something to the airway that's going to irritate it and cause all of our problems to begin with. Most people, this is going to be either exercise or some sort of airway pollutant like cigarette smoke or a pollen or environmental allergen, something that irritates these lungs, and they're going to have a hypersensitivity reaction to it. So we inhale an irritant, and then we have this bronchial hypersensitivity. Remember, the bronchioles are those airways deeper down in the lungs, so we go from the main stem bronchi into the lung tissue, where the bronchioles branch out and eventually down to the alveoli. Those bronchioles are going to be hypersensitive to whatever this irritant is, and it's going to cause this hypersensitivity reaction. We're going to see airway inflammation. It's going to elicit an immune system response, basically. Our white blood cells and our mast cells are going to swarm to this area because of this hypersensitivity response. We're going to get swelling, and we're going to get a histamine release. So with that swelling and histamine release, okay, we've got this immune response that's going to cause all of this pressure on the airways, basically. They're going to decrease in size, less room for air to move in and out of the lungs. On top of that, we're going to see an increase in mucus production. Okay, so we're taking up even more of that valuable space that's already shrinking is going to be taken up with mucus. And then finally, all of that combined wraps up to lead us to increased airway resistance. So it is harder for air to move in and out of a smaller tube, right? The smaller the tube gets, the higher the resistance, and that's what's going to cause the wheezing on expiration that we see with these asthma attacks. Hopefully we treat it before it gets too bad, because the worse this gets, the more life-threatening it will become, and eventually, if it gets bad enough, your patient will need ventilator support. So that's the reason why we want to stop these asthma attacks as soon as we can. We actually have tests designed for kids to be able to use before they go do activities to measure their lung function, so that we can see how well their lungs are doing before and afterwards, so that they can hopefully catch worsening symptoms before they actually start feeling the bad symptoms. Okay, so we've talked about what causes asthma. Now let's talk about what to look for as far as triggers and symptoms. Okay, so these lists are not exhaustive, but hopefully it covers all of the basics and most common ones. Let's start with our triggers. What actually can cause asthma? Viral respiratory tract infections. All right, again, anything that irritates that airway, an infection, perfect source, okay, will cause all of the cascades in an asthmatic patient. Exercise or stress, okay? Anything that gets them breathing too hard, increases that oxygen demand, eventually could irritate the airways enough to induce an asthma attack. Stress could be either physical or emotional stress, okay? Strong emotional responses can bring on asthma attacks in patients. GERD, oddly enough. You'd be amazed how many people actually have GERD in America. Many adult patients do, so this is one that you may see a lot in adult asthmatics. But think about it, as that esophageal reflux comes up into the back of the throat, if you end up having any of it go under the epiglottis into that airway, okay, that can trigger that response needed to bring about an asthma attack. Environmental allergens, we've already talked about that one. Anything that comes in there, okay, pollen, cat allergies, dog allergies, anything like that. Use of beta blockers or aspirin can actually bring about an asthma attack. You'll see that more in adults. Typically children aren't on beta blockers or taking aspirin too often. So adults with heart disease maybe, after heart surgeries, things like that. If they're an asthmatic, those meds may not be an option for them. Tobacco smoke and fumes, seems pretty self-explanatory. Okay, anytime you're breathing that in, it's going to go into the lungs, could cause that hypersensitivity reaction. And then last one on my list here is actually obesity. Obesity makes pretty much everything worse as far as illnesses go. So anytime we have patients who struggle with obesity, that's a comorbidity on top of these other diseases. So patient education, again, always come back around to that. Anything you can do as the nurse to help those patients improve their quality of life and able to function with their activities of daily living will help them and make you a better nurse. Moving over to our symptoms here. The classic symptoms of asthma are going to be that wheezing on the expiration and a cough, okay? The airway is irritated, it's shrunken because of all the inflammation and mucus production. So of course we're going to see the wheezing, and that irritation will produce a cough reflex as the body tries to clear whatever is causing the irritant. Mild chest pain, especially after all that coughing. That one, sometimes you see it, sometimes you don't, but you could have that there. Respiratory distress, pretty obvious, and that's going to worsen as the symptoms of asthma progress. So the farther along it gets without the treatment, the worse that respiratory distress is going to get. Hopefully we catch it before it gets too bad. Positioning. Your patients will try to position themselves in a way to make breathing easier. Typically what we'll see is some sort of tripod position where your patient is leaning forward, propping themselves up either on their elbows, on maybe a table, or leaning against something. Leaning forward takes pressure off of the chest wall and the lungs. It helps them expand easier. So when patients are tripoding, making themselves a tripod, leaning against something, that is a very easy to recognize sign that maybe they're not feeling like they're getting enough air. And that feeling is usually coming from somewhere. So always be monitoring patients, watching for that just in case. These symptoms will get worse at night. Later in the day, towards evening, they will start getting worse and more likely to have an asthma attack. And then last one on my list here is the silent chest, and this is a medical emergency. If you suspect your patient's having an asthma attack and you go to listen to their lungs and it's completely silent as they're breathing in and out, that means there is no airflow going through their lungs whatsoever. The airways have progressed to the point where they are shut, there is no air movement, and this patient is no longer getting any oxygen into or out of their lungs. So, medically emergency, gonna need some pretty serious interventions for these patients. Okay, so next, let's talk about treatment and what we're going to do as the nurse. Treatment for asthma, very simple. Rescue inhalers. Those are your beta-2 agonists, most commonly albuterol. It's a bronchodilator. They take 2 puffs of the inhaler and hopefully symptoms go away. If it's true asthma, they will. So we want to catch that before it progresses to the point where they are incapable of actually taking those puffs. So those are going to be your beta-2 agonists. We want to try to remove any irritants that might be causing it. Okay, the best treatment, prevention. If we don't have to have an asthma attack, then why should we? And then we want to try to calm that patient. Anxiety, emotional stress can actually bring about worsening asthma symptoms. So, treatment's pretty simple there. Let's talk about what we can do as the nurse to help these patients. First off, we want to try to reduce patient anxiety. Okay, patients can tell when nursing professionals and doctors are anxious. They can kind of feed off of that, and it makes things worse. They will know if you're worried about them being able to breathe, and that will stack on top of it and make the problem worse. Try to reduce that anxiety, calm the patient, practice that therapeutic communication that you learned about in your first nursing classes, and work on just getting that patient's anxiety levels down, help them breathe easier. If there is a trigger in the room or in the area, say you're out in public and someone starts having a potential asthma attack and someone's smoking a cigarette nearby, get that person away from the cigarette. Anything that could be causing that irritation to the airway, okay? If it stays in the vicinity of the patient, it's going to keep progressing. Get them out of there, okay? Educate your patients, always. That should always be on our list of nursing interventions, is education. If we can get them to reduce their weight, if we can get them to maybe stay away from irritants, teach them what irritants may actually be causing it, and just try to get these patients more familiar with signs and symptoms, fast action for treatment, they will have better outcomes in general. Like I already said, weight reduction, okay? Obesity is a comorbidity for almost everything. So if we can just get that weight reduced a little bit in patients who are a little bit on the heavier side, that will improve their symptoms and their outcomes. Administer meds if you're in the hospital setting or if you're just out in public and someone's having an asthma attack. If they've got a rescue inhaler, get them to use it, okay? Just 2 quick puffs there, breathe it in nice and deep, and we'll fix the problem right there. Afterwards, we're always going to monitor the patient. That should always be one of your thoughts as you're thinking on those tests. What does the nurse need to do? After we've done our interventions, watch to make sure they're actually working. We need to go back and reassess those patients. We need to watch their oxygen. We need to watch their breathing. We need to see how they're actually doing after we give those meds, and are they working? And then finally, respiratory support. If it's been, progressing to the point where it's really, really bad, we want to start with our obviously smaller, more simple respiratory support. Just get that patient to an easier breathing position, give them some oxygen if they need it. But if it's progressing to the point where it's really bad, they may need to actually get respiratory support via like an ambu bag mask, or they could actually need intubation if it progresses too far. So we want to start small early before we actually need to progress to those more urgent respiratory support steps. But know what you need to be doing as the nurse. If they can't breathe, we're going to start breathing for them. So we need to be watching those as well. Alrighty, and then lastly, before we wrap up the video, I want to talk about why we actually care so much about asthma, because it's so easily reversible with these beta-2 agonists, right? 2 puffs of our inhaler and our symptoms should be gone. But why do we actually care so much when it's so easy to fix? It's not always caught in children, okay? So it's sometimes just taken for exercise intolerance or allergies, and as these symptoms worsen, they do have permanent changes. So we want to be catching these kids as early as possible when they're having these asthma symptoms. We want to be doing testing on these kids, testing on people with symptoms to make sure that they don't actually have asthma. And if they do, getting them treatment as quickly as possible, because the sooner they have treatment, the easier it'll be to deal with. Typically, you grow out of asthma, and it's not that hard to live with it as long as you have the proper treatments, okay? But even though it's reversible, when it's not treated, we have permanent problems that can arise. So untreated asthma attacks, as we know, we've already talked about, they can be fatal. They can progress to a point where you need respiratory support. Even if they're not fatal and the asthma attack subsides on its own, we can eventually have permanent structural changes that occur from these asthma attacks that will be very not beneficial for your patient's airways. Eventually, these changes will progress to deposits of collagen inside the lungs. The basement membrane of the lung epithelium will begin to thicken, and we will have smooth muscle hypertrophy or growth. Typically, we don't want smooth muscle to be growing when it's not supposed to. Happens in the heart sometimes, happens in the arteries. In this case, it's in the bronchioles, and that smooth muscle hypertrophy in the bronchioles, what we're concerned about is that as it grows, the only way it can grow is inwards, or if it does go outwards, it infringes on the lung alveoli. But as it goes inwards, it's going to start reducing the space for airways. So you're already narrowing the airways, and that's permanent, cannot be changed, okay? So between these structural changes, eventually they'll progress to make your patient even worse and worse off. So we want to try to stop those before they happen by testing with pulmonary function tests, checking kids that have symptoms, and getting them the proper treatments to make sure they can deal with their asthma. Thank you for watching the video. If you enjoyed it, drop a like and a subscription. That really helps. I'd appreciate any comments from questions that you guys might have. And if you haven't already checked it out, I do have a video on bronchodilators that will help explain some of how they work and all the different kinds of drugs that we have there. There's a few classes that it goes over, so that will be beneficial in asthma treatment as well. So go check that out, and thank you for watching.